Hey, everybody. This is Dr. Adam Rodman, and along with Shreya, I co-direct the IMED initiative. That's the Innovations in Media and Education Delivery at Beth Israel. I'm also the director of AI programs at our research center, and I lead the task force for the integration of AI into the Harvard Medical School curriculum.
And before we dive into today's episode, we have some exciting news to share.
That's right. The IMED conference is back. If you are passionate about technology, medical education, and what all of these exciting changes mean for the future of our field, boy, do we have a conference for you. The Conference on Digital Education and Artificial Intelligence.
Yeah, so we're going to have some really great panels. We're going to get into the weeds of how to get paid for what you love to do. How can you use AI to optimize your work-life balance? It's going to happen virtually on January 10th, Digital Education and Artificial Intelligence Conference.
You know, Shreya, what I've always, biased here, but what I love about our conferences is even though they're online, they're super hands-on. And we have integrated so many cool hands-on activities into our conference. Like we're going to have a promptathon this year. We're going to get people learn how we can make large language models work for you as a busy medical educator.
Or even just like some of the administrative tasks we have to do day to day. Like, I hope someone's figured out how to use ChatGPT to like fill all the credentialing paperwork we have to do like every few years. It's just, that would be really helpful.
Yeah. And I mean, I think that is the goal of our conference. It is practical. It is not one of these, what is going to happen 5 to 10 years from now? It is what can you as an educator be doing to make your life easier and you a better teacher today? You're not going to want to miss digital education and artificial intelligence. Follow the link in our show notes, fill out the registration, and we will see you on January 10th.
It's a huge health issue for the country. We've got really an epidemic of amputations happening across the U.S. that are preventable if we can identify this disease earlier in its course and get people on the correct medical therapies. It's over 200 million people in the world that have PAD. So it's not as if it's that rare zebra. I think it's there all the time in front of us and we're just not looking for it.
That's Dr. Daniela Kadian-Dodov, a vascular medicine specialist at Mount Sinai Hospital, talking about peripheral artery disease, aka PAD. Welcome to the CoreIM 5 Pearls podcast. This is Dr. Shreya Trivedi.
And I'm Dr. Arti Rao, a cardiology fellow at Beth Israel Deaconess Medical Center. Today we are covering peripheral artery disease, aka PAD.
Let's get started with the pearls we're going to be covering today. Be sure to test yourself by pausing after each of the 5 questions. Remember, the more you test yourself, the deeper your learning gains.
Pearl 1. When to suspect PAD.
How does peripheral artery disease present, and what are the major risk factors?
Pearl 2. How to work up PAD.
What are the key exam features to look out for? What's an ABI, and what are the limitations to the test?
Pearl 3. What therapies improve symptoms in PAD?
What medications actually improve symptoms and quality of life? And what's the impact of supervised exercise therapy?
Pearl 4. Preventing cardiovascular mortality.
What medications actually help prevent cardiovascular events down the line, and what do we actually prioritize?
Pearl 5. A deeper dive into antithrombotic therapy and anticoagulation.
What's the role of rivaroxaban, and is there any indication for DAPT?
And a sneaky Pearl 6. When to refer patients for revascularization.
So Dr. Kadian-Dodov mentioned that peripheral artery disease is staring at us all the time. It's in front of us and we're just not looking for it. So Arti, help us be a little bit better about finding it when it's in front of us and missing it a little less.
Yeah, Shreya. I think part of the issue is that we're often taught that PAD presents with these classic claudication symptoms.
Right. So this is going to be the classic patient who's coming in with lower extremity pain, consistently induced with exercise, consistently relieved by rest within a few minutes or so.
But in reality, and I was pretty surprised to learn this, only 10% of patients have these classic claudication symptoms.
Oh, 10%? Man, I can now clearly see why so many of us miss it. Okay, so if peripheral artery disease doesn't really present with this classic claudication that we learned about, then how does peripheral artery disease manifest in our patients?
So, depending on what study you read, about 50% of our patients actually have atypical symptoms, like kind of a vague leg heaviness. Sometimes it's leg tingling, sometimes it's just fatigue. And many patients don't have any leg symptoms at all.
Oh, that's crazy. All right, so now I'm really curious. The peripheral artery discussants you talked to, what did they have to say about some of the atypical cases they've seen?
So, first up, we have Dr. Teresa Wu, a vascular medicine specialist at Cleveland Clinic.
I can think of one patient of mine actually who initially presented to his PCP with what he described was hip pain. And there was pain specifically at his hips and kind of in his buttocks.
And this patient of hers had an x ray, was initially diagnosed with arthritis, and then, despite getting physical therapy for his arthritis, had worsening hip pain.
And so he eventually made his way to me, and we ended up doing some testing and found out he had really bad aortoiliac disease causing buttock claudication. And he ended up going for an intervention for that and ended up feeling a lot better. But it can be tricky. So you really have to have a high index of suspicion.
And so maybe the bigger lesson is, yes, patients can have atypical symptoms. So you should really be thinking about PAD in patients with any risk factor for atherosclerosis who really have any lower extremity symptoms. And this could be hip pain to just leg tingling.
Yeah. And to make sure we're all on the same page, when you talk about risk factors, what are we looking for in our patient's one-liner to make our spidey senses really go up for PAD?
So the kinds of folks I would be suspicious for PAD would be those who are over 65, anyone who's ever smoked, who has diabetes, kidney disease, and hypertension. And if they come to you with any symptoms of leg discomfort or pain, it's really important to ask the right questions and tease out whether or not their symptoms could be from true claudication from PAD or not.
So I'm all about being curious and asking better questions. So I'm curious, what are the questions that can then help us tease out whether these symptoms are peripheral artery disease or not?
It can be really hard, truthfully, sometimes to distinguish between true claudication or other mimickers of true claudication. I would say probably the most useful question to ask to help differentiate causes, different types of claudication would be, how is the pain relieved and how long does that take?
I think how the pain is relieved and how long it takes for that relief nicely helps differentiate mimics of PAD, like spinal stenosis or venous insufficiency. So with PAD, symptoms should improve quite quickly with rest, like we're thinking within a few minutes. But in spinal stenosis, pain typically isn't relieved with rest alone. Patients often find that relief with leaning forward or sitting down.
Man, the way you describe classic spinal stenosis reminds me of those question stems from back in med school where it'd be like somebody at the grocery store and their back pain only feels better when they're leaning over their shopping cart.
Oh my God, sure. That reminds me of step 1 studying, and I can just envision the page on first aid.
Yes.
And then just to kind of wrap up this point, when you think about venous insufficiency, the discomfort in that situation usually takes longer to improve. So we're thinking on the order of 15 minutes to improve after rest. Whereas in peripheral artery disease, the pain usually gets better after just a few minutes.
Ah, great. Oh, that's such good points here. Okay. So let me wrap up kind of and synthesize Pearl 1 and what I'm taking away. I think the main takeaway for me is to think about peripheral artery disease in someone who's over 65, who's ever smoked, has diabetes, kidney disease, high blood pressure, who's presenting with any symptom of lower extremity or hip discomfort. And they can describe it with kind of vague heaviness or tingling. And then I think for me, I'm going to make sure to ask about how that discomfort is actually relieved, and more importantly, how long does it take, with an eye for if it's peripheral artery disease, it's going to be relief that comes pretty soon after rest. Okay, so say we're in clinic or in the hospital, our patient has some vague complaints, maybe it's on exertion, maybe we already know that this person already has a lot of atherosclerotic disease in their coronaries. It's not unreasonable to think, maybe they also have it in their peripheral arteries too. So, Arthi, how do we then go about the exam and workup if we really want to investigate if those vague leg complaints are coming from peripheral artery disease?
So, to get into all of that, I sat down with Dr. Eric Sasemsky, a vascular medicine cardiologist at Beth Israel Deaconess Medical Center.
I mean, I think the exam is incredibly important here. There's going to be some loss in hair distribution, some changes in nails, thinning of skin that you can see with PAD, but most reliably really is the pulse exam in my experience. And so the pulse exam is really good for ruling in disease, in particular when you can't feel those pulses at all, but it's not always a slam dunk for ruling out disease.
Okay, so the thing here is to find those pulses, start with the femorals, make our way down, all the way down to the ankles, find those posterior tibial pulses, and then on the top of the foot, dorsalis pedis arteries.
So, if you can't feel pulses, you can be pretty confident that a patient has PAD. The specificity of that is around 90%. But if you can feel pulses, a patient can still have PAD. The pulse exam has a wide range in its sensitivity, anywhere from 30 to 70%.
Okay, but Arti, explain to me then, why is it that patients can have peripheral artery disease but still have palpable pulses?
So I love thinking about this because it brings us back to the pathophys. So you can imagine that a patient might have a partial blockage that still allows for some blood flow, or that the body has formed some collateral vessels that supply blood flow beyond the narrowed artery.
Yeah, I guess that makes sense. And then I can also imagine, some patients having segmental disease and it's only affecting parts of the arterial tree. So they would then have palpable pulses in the segments that are unaffected and maybe where you're, pressing down to feel little pulses.
Yeah, exactly, Shreya. And a quick physical exam pearl here is that the absence of the dorsalis pedis pulse, so that's the one on top of the feet below the toes, is actually less accurate. So the reason for this is that the dorsalis pedis pulse is absent in a significant percentage of healthy patients.
Man, that's kind of a bummer because honestly, the dorsalis pedis was the one that I felt the most confident in finding. So, womp womp.
It does honestly make me feel a little bit better about the times when I was really unsure about my pulse exam in clinic. And then it does emphasize why objective testing is just really needed to confirm the presence of PAD.
Yes, and what a perfect segue to ABIs, aka the Ankle-Brachial Index.
We have an incredibly easy screening test that is cheap and not harmful to the patient. And so that's what I love about a lot of the vascular investigation is it's readily available, it's affordable, and there's almost no cost from the exam itself to the patient.
Okay, so Arti, can you help us connect why the ABI might be so readily available and so affordable?
So it's essentially just a ratio that compares the blood pressure in the lower extremities to the upper extremities. So you measure the systolic pressure from the posterior tibial or dorsalis pedis artery in the ankle and just divide that by the systolic pressure from the brachial artery in the arm.
And there's going to be a great graphic by Dr. Jesse Paul. That's a good reminder that the ABI is just a ratio of the different blood pressures from the extremities. And it just makes it so clear how we get that ABI. And it didn't really click for me until I saw that image. Arti, say we do order that ABI, we get back a number. Help us then interpret that ABI result.
So values between 0.9 to 1.3 are considered to be normal. And anything below 0.9 gives you a diagnosis of PAD. So the number to remember is really 0.9 because that or below is a diagnosis of PAD.
Okay, that's great. I think I knew that the lower the ABI, the worse the peripheral artery disease. But what if we get a number back and it's above the normal range, right? What if the ABI is above 1.3?
A lot of patients, especially with diabetes, have non-compressible arteries. So if you have an ABI of around 1.3 or higher, we know that one, you can't definitively say yes or no, they have peripheral artery disease. But two, many of those patients still have a global cardiovascular risk based on just having an elevated ABI.
So we often do see ABIs above 1.3 in these patients that have really calcified vessels. And this will happen just because with peripheral artery disease, the vessels become stiff and non-compressible. And if you think about what happens when you measure blood pressure with a stiff vessel, the arteries just don't compress as they normally would. So your reading actually reflects that extra pressure that's needed to compress those really stiff arteries. And then that leads to an inappropriately high ABI result.
Yeah. So I imagine sending off a patient to get an ABI, getting back a lot of results that are greater than 1.3. So I'm curious, and what's the next step once we get the ABI back greater than 1.3?
So you can actually use a toe brachial index. They'll put this tiny little toe cuff on the big toe and use that as a surrogate. And this works because the vessels in the toe are actually much smaller and easier to compress, even with the calcifications.
Wow, I did not know they made blood pressure cuffs this small. Kind of cute to even think about.
I thought exactly the same thing. And when I gave this talk to the IM residents, I had to put a picture of the little toe cuff just for a dramatic effect.
Oh my gosh. Do they gasp?
They did gasp. So let's bring this back to clinic. What if the ABI just came back as normal? Are you done with your workup?
I'm guessing the answer is no, seeing this is an episode on peripheral artery disease. We still have multiple pearls left, and you, my friend, are asking a very leading question.
It is also really important to do stress testing because a lot of patients can have disease that is essentially not physiologically evident at rest, and it only gets unmasked when they exercise. So the way I like to equate this is say someone coming to your office with saying they have chest pain with exertion. You just get an EKG in your office, and if it looks normal, would you tell the patient they don't have a true angina or a CAD as a cause of their chest pain? Probably not. You're going to send them to get a stress test. And that's the exact same way I like to think about getting a stress or exercise ABI in patients with PAD. You have to really perform a functional assessment.
Wow. So you're telling me we can have a patient who has a very normal physical exam, normal ABIs, who actually might end up having peripheral artery disease that's only discovered after a stress test of the lower extremities?
Yes. And this is why in patients with any risk factor for PAD that has really any lower extremity symptom, your workup is absolutely not done if the ABI is normal. Those patients need a functional assessment.
So then what exactly does the functional assessment of peripheral artery disease look like?
So what they'll do in the lab is they'll check an ABI at rest, then put the patient on a treadmill and then check the ABI again after exercise. And for your patients who might not be able to walk, they'll have them do toe raises instead.
Nice. Okay. There's a lot that we just went through. So why don't we just cement that a bit more? So when I'm trying to assess if this is peripheral artery disease or not, the pulse exam will be my first step, but I'll make sure to remember that this is not highly sensitive, meaning that if I find a normal pulse, it doesn't rule out peripheral artery disease. And then I'll go ahead and order an Ankle-Brachial Index, an ABI. But then keeping in mind in patients with, say, diabetes, CKD, advanced age, they just have a higher risk of having those calcified, non-compressible vessels. And then we might reach for a toe brachial index. And then last and most important thing is that if someone does have risk factors for peripheral artery disease and leg symptoms with a normal ABI, I need to make sure I remember, hey, the workup is not over. I really need to get a functional assessment to see what their ABI is with movement to really get PAD off the table and rule it out. Okay, so say we diagnose peripheral artery disease. Now, onto management. How do we actually help these folks?
I think that it often gets misunderstood by patients that once you have PAD, you're on this road to needing some sort of procedure or surgery down the line. But in fact, that really only happens in a minority of people with PAD. And typically people who are not medically managed properly or who continue to smoke. But really with intensive medical therapy and through exercise therapy and risk reduction, only a small minority of these people ever develop any sign of limb-threatening ischemia or require something like an amputation.
Okay, so the majority of people don't need to be revascularized with stents or fem-pop bypasses or need amputations. So then how do we manage most patients who aren't going down that pathway?
The way I like to think about medical management is that it's really twofold here. So number one, we want to prevent cardiovascular morbidity and mortality, and that includes heart attacks and strokes and adverse limb events. And then number two, we want to improve function and quality of life.
Okay, a twofold management when it comes to peripheral artery disease. We're going to get into all things of that first branch point in terms of preventing cardiovascular mortality in pearls 4 and 5. But let's get into that second branch point in terms of improving symptoms and quality of life. I think, honestly, this is the thing our patients care the most about.
And the main medication we have for symptom improvement is cilostazol. And as a reminder, this is a phosphodiesterase inhibitor that inhibits platelet aggregation and leads to vasodilation.
It's a little frustrating and disheartening that it's the only medication out there that we have to treat claudication still today. It's not entirely clear how it works to improve claudication, but if the patient can tolerate it, it seems to really make a difference. For those that can tolerate it, it can increase the maximum and pain-free walking time by 67%, or in 67% of patients. But about the same number, 60% or so, tend to be intolerant because of side effects like GI upset, headaches, dizziness, you name it. The good news is once you stop the medication, that goes away pretty immediately. But I always warn patients that these side effects are known. We never know who's going to get them until we try the medication.
So not only do over 60% of patients tend to be intolerant of cilostazol, the other big challenge is that it can take up to 3 to 6 months for the medication to take full effect and for them to feel any of that symptomatic relief.
Arti, that is a bit of a tough sell, right? Like 3 to 6 months is a long time for a patient to wait before they feel better, especially when the medication can give them, pretty tough side effects, GI upset, headache, dizziness.
And then the last key point, and then yet another barrier to using cilostazol, is that it does carry a black box warning for patients with any history of CHF.
Oh, that is challenging, right? A lot of those risk factors for PAD are also connected to a drop in their EF. So I guess I'm curious, say we have a patient who either can't tolerate cilostazol from the side effects, can't wait 6 months for it to take into effect, or, maybe has heart failure. I'm curious if there are other therapies that we can offer, then what else is on the table? What are other therapies that we can offer our patients to help them, feel a little bit better?
So this is where supervised exercise therapy comes in.
I gotta say, I think we always say exercise for everything. I'm kind of curious, how much does exercise actually make a difference here?
I have one patient of mine, actually, when I first met him, he could not walk down the hallway outside my clinic without developing claudication, essentially. And we got him on a program. And after about 2 or so months, by the time when I saw him back, he said he was doing laps around the mall. And he said there was no way he could have done that before. But he stuck with it, and it really, really works. But you have to stick with it for it to work.
Wow, it kind of seems like voodoo magic here, like too good to be true. What actually happens in supervised exercise therapy?
So the exercise program itself is a graded treadmill program where they try to pretty much walk you, push you to your pain point, and then try to keep advancing you on that treadmill to get to the next level.
And what they will have the patient do in those sessions is exercise to the point of claudication pain, stop and rest, and then go again. And they do that stop, rest, or go rest cycle rather for 45 minutes to 50 minutes at a time. And that's pretty hard if you think about it. Like you're asking this patient to be in not insignificant pain for 45 to 50 minutes at least 3 times a week.
Wait, so I'm asking patients who might already be in pain to go exert themselves until they feel pain again and do this at least 3 times a week. Again, a tough sell, my friend. You're really curious here. What is in the theory behind why this type of exercise actually works in peripheral artery disease?
Yeah, there's a lot of theories behind that. That's a great, important question. Yeah, I think of it as there's some degree of angiogenesis that can be prompted with, advanced exercise like that. So really helping, build an extensive network of collaterals for people who have more occlusive disease. And then there's also just the local effects of muscle strengthening, accessory muscles, and just, got a lot of these patients are deconditioned and aren't very ambulatory at baseline. And so enriching the supportive environment can also help a lot with that pain response.
Wow, I can't wait to tell patients that they're going to make new blood vessels when they exercise in response to the hypoxia and the increased demand.
Yeah, I think patients can really get behind the idea of building new blood vessels when they exercise. And again, as a reminder, this is just the hypothesis of how this works. That being said, there's great evidence behind the use of supervised exercise therapy.
What they found in that Clever trial was that you get similar impact on claudication onset time, how early did your symptoms start, as well as the degree of symptom pain between a stent and a exercise program. So, I mean, pretty slam dunk win for exercise program. And they did a year and a half out study, follow-up study, and there was persistent benefit in each group. So exercise really came out of that as we're as good as stents, which should be used before surgery or interventions recommended. And so, I think that supervised exercise therapy has a tremendous role in this place.
Wow, it sounds like before we refer our patients with symptomatic peripheral artery disease for a stent, they really deserve a trial of exercise.
Agreed, Shreya. It seems like this is super important for our patients to get. And I do remember during primary care clinic how it could be very hard to get these referrals through, with my patients often waiting months to even start their first session. So it was really great to hear that there are home-based programs for exercise therapy.
Yeah. So this does come up. Unfortunately, supervised exercise therapy is not always accessible to everybody, especially in patients who live very far away or who have mobility issues or transportation issues. And so there are home-based programs that people can do. I personally have my own home-based program that I give to my patients. It outlines essentially the different steps to doing this. And I tell them to do it, ideally 45 minutes, about 3 times a week.
And we'll make sure to link these kind of home-based programs in our show notes for anyone who's interested in sharing with their patients.
On that note, let's wrap up Pearl 3. So to improve claudication symptoms, there are really 2 things on the table: cilostazol and then supervised exercise therapy. As a reminder, cilostazol is a phosphodiesterase inhibitor that improves claudication symptoms but is associated with significant GI side effects, headaches, and dizziness, and importantly can take up to 3 to 6 months to work. Remember, it should not be used in patients with any history of CHF.
And then I think my biggest takeaway in terms of helping people feel better is to refer them to supervised exercise therapy, where basically patients are exercising to the point of claudication. And this is shown to help in overall functional status, quality of life. And what's crazy is that supervised exercise can be just as good as stents in terms of symptom improvement. All right, now that we've covered that one arm of therapy to help people feel better with their symptoms, let's dive into the second arm of management, preventing cardiovascular mortality.
That really includes several things. So antithrombotic therapy, cholesterol optimization, blood pressure control, glycemic control in those who have diabetes. And then at the very top of the list, smoking cessation, number 1, 2, 3 for anyone who smokes.
So that's a lot. And it is the bulk of what we actually care about in internal medicine too. So I think to keep it a bit more manageable, and for those of you who like a good mnemonic, something I actually do write down in my notes under the hashtag PAD is SALAD. Okay. So the S is for smoking cessation. The first A is for antithrombotic or antiplatelet therapy. L for lipid lowering, A for antihypertensive, and then the D for diabetes control.
I was never a mnemonic person, Shreya, but I have to say it is pretty catchy.
You are welcome. We're very, very welcome.
And thinking a bit about what Dr. Wu said, something I've really changed in my practice after prepping for this episode has been prioritizing smoking cessation during visits for PAD. I feel like I used to go into these visits with 10 different issues to address, and smoking cessation often fell by the wayside, but now I make it a point to talk about it at every visit.
When I think of my patients with PAD who continue to have disease progression, or unfortunately my patients with PAD who've undergone revascularization and keep requiring repeated revascularization, it's almost always patients who continue to smoke. And I always tell patients, leave the rest up to me and we'll get the blood pressure, the diabetes, the cholesterol under perfect control. But, the one thing you got to work on is the smoking.
All right, so let's set up our patients for success. And not to toot our own horn here, but I honestly do go back to our CoreIM smoking cessation infographic that Dr. Cabo Wang did. It just like so nicely lays out the options.
I love that episode too, Shreya, and it's such a good overview of therapies like nicotine patches and mini lozenges, or the two non-nicotine options like varenicline or bupropion.
Yeah, definitely. So that was the S of the salad mnemonic. Let's get into the first A, antiplatelet antithrombotic therapy. I think this is where people will start to have questions, right? According at least to the ACC/AHA guidelines, all patients with symptomatic peripheral artery disease should be on an antiplatelet therapy to reduce cardiovascular events. And this is going to be either with aspirin or clopidogrel.
And my feeling is if you have a diagnosis of peripheral artery disease, I think it was a secondary, not primary indication for aspirin therapy because I'm diagnosing you with an atherosclerotic condition. The PAD is an understanding that this is a systemic process and they're much more likely to have a major heart attack or stroke than they are to have an amputation. And so, antiplatelet therapy for peripheral artery disease is primarily indicated for anybody with symptomatic disease.
So the key here to remember is that this is only in patients with symptomatic PAD. So not in patients who have PAD on ABI or just on imaging who don't have symptoms of claudication or leg fatigue. And the idea here is that patients with symptomatic PAD are really at a much higher risk of cardiovascular events.
Great. So I think the takeaway for me is to think about peripheral artery disease as a kind of the systemic atherosclerotic process. And for those who have symptoms, we really want them on an antiplatelet agent like aspirin or clopidogrel to prevent them from having cardiovascular events down the line.
And stay tuned for Pearl 5, where we unpack antithrombotics like rivaroxaban versus antiplatelets.
Nice. I can't wait to get into that. Okay, so let's move on then to the L of the salad mnemonic, lipid-lowering therapy.
So for the L, statins really are the mainstay of lipid-lowering therapy and should be prescribed to all patients with PAD.
And there are really only two statins that should be used. Atorvastatin, 40 to 80 milligrams a day, or rosuvastatin, 20 to 40 milligrams a day. So the high potency statins, and we want to drive those LDLs below 70. In some patients with polyvascular disease, I might even be more aggressive and drive their LDL below 55.
All right, so I think we have covered the SAL of salad. On to the second A, antihypertensives.
So the overall goal here for patients is just to make sure that they have well-controlled blood pressure. So it should be below 130/80. ACEs and ARBs are generally preferred, and this is based on older trial data.
Yeah, there are several studies historically that have shown that amputation risks are lower for patients who are on an ACE or an ARB versus no therapy when hypertensives. Again, I think many of us, again, who practice in cardiology see the global benefit of ACE and ARBs, as everybody's observed also with their diabetic patients, with their heart failure patients. And so, that one, has come out of older literature, but has seemed to really make an impact in the global cardiovascular health that we emphasize it.
And finally, to make the salad mnemonic complete, we have our last letter, D, for diabetes management.
So this is a really exciting space. There's now a class 1 indication to use certain GLP-1 agonists and SGLT2 inhibitors in patients with PAD.
I'm surprised to hear about the SGLT2 inhibitors. I remember a lot of hesitance with using SGLT2s, especially in people with PAD, because there was that risk of amputation as a side effect. But it seems like that's no longer a case.
And it was quite frustrating because C1, as I'll call it now, had a trial. And in their trial, there was this signal of greater risk of amputation among patients who were on that agent. And it was, interestingly, not seen in trials for other classes of SGLT2, other agents of SGLT2 inhibitors. So there's a big investigation on this, and they went back and looked at several other studies and some real world evidence, and couldn't reproduce this harm signal. And so it had an FDA black box warning for a moment, and then that was taken off.
So that was Dr. Sasemsky specifically talking about canagliflozin, or as he likes to call it, the C1, and how there's no longer an FDA black box warning for risk of amputation.
Yeah, I'm so glad we went over this because I think once something gets a label, a bad label, it's really hard to, shake off. But it seems like after reviewing the newer trial data, the risk of amputation is actually lower than initially thought.
And you can check out our show notes for the relevant trials. But the takeaway here is that the first line management of diabetes in someone with PAD includes GLP-1s.
So that's liraglutide, semaglutide.
And SGLT2 inhibitors.
And the ones that have been studied are canagliflozin, dapagliflozin, and empagliflozin. And the way I remember it is like CDE. Those are the ones that have been studied so far. Canagliflozin, dapagliflozin, and empagliflozin. All right. So with that,
nice job with the pronunciation, Shreya.
I know. And I'm done. All right. So to wrap up Pearl 4 on cardiovascular prevention, if we use a SALAD mnemonic as kind of a checklist, we ask ourselves about the S. And again, this S is the most important, is how can we help our patients with smoking cessation? Then for the A, are they on an aspirin or a Roxban? And we're going to get a little bit more into that just in a second. L, lipid lowering, are they on a high potency statin? The second A is antihypertensives, are they on an ACE or an ARB? And then for the D, diabetes, have they been on one of the studied SGLT2 inhibitors or GLP-1s?
So I have to say, this is the Pearl I was probably the most excited about. There were so many times in primary care clinic where I would see patients with PAD on antiplatelets like aspirin or Plavix, and then an anticoagulant like rivaroxaban. And it was always really challenging to figure out the exact indications for the medications and then the time courses that they should be on those meds.
Yeah, same. And I think we're always thinking about bleeding risk, and I always like the idea of peeling things off, but yeah, I'm not sure of the best practices when it comes to PAD blood thinners.
So I think it might be helpful to start by addressing if there are any indications for dual antiplatelet therapy, aka DAPT, in PAD. And by DAPT here, we mean aspirin and a P2Y12 inhibitor.
And that's clopidogrel, ticagrelor, or prasugrel.
For the average patient who has not had been treated with anything like recently, either a coronary stent or a lower extremity procedure, there is really no role for dual antiplatelet therapy.
So at least for DAPT, yes, it is indicated for someone who's had a recent cardiac or lower extremity intervention within the last 6 to 12 months. But for our average patient who hasn't had a lower extremity intervention, they really don't need to be on DAPT.
What was surprising for me to learn is that the medication that seems to have really made an impact in the PAD space has been the antithrombotic rivaroxaban.
Yeah, I've definitely been seeing that on my patients' med list more, which is interesting because I often think of rivaroxaban as something as we commonly use for venous thromboembolism. So what is the evidence behind rivaroxaban being used in PAD?
We learned from the COMPASS trial that was published several years ago that if you randomize patients to a low-dose rivaroxaban with aspirin, you can reduce cardiovascular risk, including cardiovascular death, over the long term. And a sub-analysis showed that, in particular, when you look at legs, people not only get the cardiovascular benefit, but they have lower risk of amputation and acute limb ischemia.
So that's where we got the recommendation that in patients with stable PAD, starting low-dose rivaroxaban, which is 2.5 milligrams twice a day, with aspirin, has both cardiovascular benefits and limb benefits. And this combo therapy now actually has a class 1 indication in the 2024 ACC/AHA PAD guidelines. So we're going to be seeing a lot more patients on this regimen, Shreya.
Nice. Okay. But wait a minute. Which of the patients should we prioritize both aspirin and rivaroxaban?
So we always prioritize it in people with polyvascular disease. If they've had a heart attack and have symptomatic peripheral artery disease, that's a slam dunk in our clinic to start them on low-dose Xarelto. If they've had a stroke and symptomatic peripheral artery disease, or all three. And so we really try to get that population, and then also the younger population, the population that's going to get the most benefit over the long term. If you're coming in a younger age with very symptomatic peripheral artery disease, you have to assume they have coronary artery disease, and we like to put them on that agent.
Okay, so if I can recap, we should definitely be starting aspirin and rivaroxaban for patients with polyvascular disease, which means patients who have cerebrovascular disease, coronary disease, and peripheral artery disease. And then it should also be strongly considered in any patient with symptomatic PAD.
Great. Okay. So then what about patients who need revascularization? Those that have had a fem-pop bypass, stents placed in their legs. What's the role of rivaroxaban instead of DAPT?
Shreya, I'm so glad you asked this question because this is where the Voyager trial comes into play. And here they looked at the use of rivaroxaban post-intervention for either claudication or critical limb ischemia as the main outcomes.
And you're randomized after your treatment to either Xarelto 2.5 milligrams twice a day with aspirin or aspirin alone. Each arm could use clopidogrel if they wanted to, but they weren't obligated to. And the take home from that trial was if you were randomized to the intervention arm, the low-dose Xarelto arm, you had again, what we expected from the COMPASS trial, a better reduction in global cardiovascular events as well as limb-related events over the outcome after your treatment. And so we've really adopted this in the peripheral vascular space where we try to get patients on low-dose Xarelto, 2.5 milligrams twice a day.
Okay, so another win for rivaroxaban, showing that it does reduce cardiovascular events and limb events in the group that had both rivaroxaban and aspirin versus aspirin alone after going through vascularization.
To summarize this pearl, there are no indications for long-term DAPT in PAD. Rivaroxaban is the new medication that has really made a big impact in this space. There are two main patient groups with PAD who you may see on rivaroxaban and aspirin combo therapy. Those who have symptomatic PAD, particularly in those patients with polyvascular disease, and then those post-surgical or endovascular intervention.
Okay, one quick thing before we close out. We briefly hinted at that there's a minority of patients who are going to need a referral to vascular surgery for revascularization. And just to be on the same page, quickly, who are those people?
Similar to coronary artery disease, it can be helpful to differentiate patients into stable disease and unstable disease. So your patients with stable disease are those with claudication who you're thinking about revascularization really for improvement in symptoms. Whereas those with unstable disease are your patients with non-healing wounds, ulcers, and gangrene who might need a more urgent intervention for those clinical symptoms.
So if the patient doesn't have those urgent symptoms, they're, somebody who has stable peripheral artery disease, living with pain, when should those patients be considered for revascularization?
You can live your life with claudication and not need an amputation, which means that when you do get it referred for procedure, it's only for a quality of life issue. We've only been able to show that if you have terrible claudication that's refractory to cilostazol and supervised exercise therapy, and you can't complete your daily functions, that's a good time for you to have a discussion about a procedure.
So it sounds like it comes down to how bad is it affecting someone's quality of life if someone has stable peripheral artery disease. And it's definitely a decision that vascular medicine and surgery folks, don't take lightly.
So there's data from multiple studies showing that when patients get a revascularization procedure, they're at 4 times the risk for acute limb ischemia after that. And that is a scary statistic because acute limb ischemia is the counterpart to a STEMI, right, for the heart. But the outcomes with acute limb ischemia are far worse. So mortality at 1 year after acute limb ischemia is about 12%.
Oh, I had no idea about the risk of limb ischemia and the increased mortality that comes with revascularization. I mean, I guess it makes sense, they're going through surgery. But yeah, we should all have a high threshold before, we send patients for these procedures.
Yeah, sure, especially in those with stable PAD. And then just thinking about your patients with unstable PAD, and again, those are the ones with non-healing ulcers, wounds, or rest pain, meaning severe pain in the legs that occurs at rest rather than with physical activity, and gangrene. These are patients who really need urgent revascularization within 2 to 4 weeks.
I saw a woman Friday. She had this ulcer then been there for 3 weeks. She had peripheral artery disease. She had diabetes. It wasn't healing. She needs to get to the lab on the sooner side. We care about feet. If you get disease that threatens your foot, you're a different person because you're going to need to get at least a below the knee amputation. You're going to need to either be immobile or with a prosthesis.
Very much so. And let's round out this episode with one last word from Dr. Kadian Doda.
Just, I guess, to say that I really think that primary care, internal medicine are the gatekeepers for these patients to keep the idea of PAD in your mind when you're seeing your coronary patients or, other patients with atherosclerotic risk factors, because you could change their life. An easy referral or ordering an ABI.
And that is a wrap for this episode. If you found this episode helpful, please share it with your team, your colleagues, give it a rating on whatever podcast app you use. And if you want to learn more, check out the CoreIM website or the YouTube channel for additional resources. We have this wonderful behind-the-scenes interview that we did that you can check out to even learn a little bit more about PAD. Thank you to our reviewers, Dr. Brett Carroll, as well as Dr. Stan Hankin. And thank you to our audio editor, Jerome Reyes. And as always, opinions expressed are our own and do not represent the opinions of any affiliated institutions. Thank you. Take care.
Some of these symptoms don't have any leg symptoms at all. Sorry, start over. And many
Some of these
patients do not have any.
It's a good blooper.
Yeah. Start
Some
over.
symptoms don't have any symptoms. And I will specify a trial of supervised exercise therapy entailed 3 times a week for about 26 weeks. Okay, so a little over a year. No, that's a lie. There's 52 weeks in a year, right?
Yeah.
Yes. I was thinking about this last night. I know.
Yeah.
I'm glad we caught this now. This is like sleep deprived brain.
You can have it all. Great pay, awesome benefits, a flexible schedule, the chance to grow. At Cox, we're recruiting auto and diesel technicians to join our Mannheim and Fleet Services teams. If you're ready for a new job and want to experience an award-winning workplace, drive your career forward with us. Visit cox.career/autotech to learn more. That's cox.career/autotech.
How do you feel when you switch to Geico and save on your car insurance? It's like going to work on one Thursday morning and thinking to yourself, just one more day until Friday. But then somebody in the elevator says, "Happy Friday!" Then you check your phone quickly and discover today is actually Friday. So yes, Happy Friday, random stranger in the elevator. Happy Friday indeed. Yep, switching and saving with Geico feels just like that. Get more with Geico.